Hi, this is Steve Tunnell, and this is Ventilation Matters. Thanks everyone for joining us again. Tonight we have a very special case study. David Willms is going to share a COVID-19 illness case study. It includes mechanical ventilation, and he'll talk us through the course of a particular patient. So David, thank you so much for sharing, and take it away.
Okay, so I'm going to talk about just one patient that we've seen in the last 2 months. And I have changed some of the details to protect the confidentiality of the individual. So this is a 34-year-old male who was previously healthy, daily smoker, but otherwise no problems. About 4 days prior to admission, he had fever, chills, body aches, headache, and a mild cough. He went to an urgent care center here in San Diego. He had a rapid flu test, which was negative, but because it was flu season, and this was a couple of months ago, this was early March, really before the pandemic had hit us. Because he had a flu-like illness, he was prescribed oseltamivir. Then 3 days later, which was 1 day prior to admission, he had some worsening shortness of breath. He went back to the urgent care. He had an O2 sat of 95% on room air. He had a chest x-ray done that time, and it showed some bilateral pulmonary infiltrates. He was just diagnosed with pneumonia and treated with Augmentin and doxycycline and sent home. This was his chest x-ray that day. So you see he's got some really patchy infiltrates here in the right lower lobe, a little bit more so in the left lower lobe. And that was what was diagnosed as pneumonia. So 1 day later, and this is the date of admission, he came to the emergency room. He was complaining of worsening shortness of breath. He was observed to be unable to speak in complete sentences at that time. And he was initially admitted to the hospitalist service, but to the intensive care unit. On that day, his white blood count was 3.9. He had a grand total of 300 lymphocytes. Platelets were low at 96,000. He had a markedly elevated D-dimer of 5803 and a ferritin that was above our normal limits of greater than 2,000. He was started on low-flow nasal oxygen at about 2 to 3 liters per minute, and he was able initially to maintain an O2 sat of 94%. He had a SARS-CoV-2 test, which ultimately proved to be positive. This was his chest x-ray on the day of admission. So now he's got a little bit more infiltrate in the right middle lower lobe, and the left lower lobe, maybe in the left upper lobe. Hard to say, but certainly a little bit of progression from the urgent care film. So on the second day in the hospital, he was advanced to an oxidizer cannula from a regular cannula. His temperature spiked at 40 degrees centigrade. He was found to have a respiratory rate 38 to 40. He was labored. At that time, and this was very early in the pandemic, the hospitalists who were taking care of him, they were concerned about the use of high-flow nasal cannula and non-invasive ventilation. They thought those were contraindicated due to the potential for aerosol risk. And so we were consulted. He was intubated, lines were placed, and he pretty immediately required high-dose sedation and paralysis. So this is his chest film on the day of intubation. This is only hospital day 2, remember. So now he's got somewhat more consolidation bilaterally, basically 4-lobe disease, 4-quadrant disease at least. On this day, he was placed, we have Hamilton ventilators, so he was put in the APB-CMV mode, which is roughly equivalent to PRVC. He had a tidal volume of 450, which for him, he was pretty tall, so that's a 6.2 milliliters per kilogram body weight. Tidal volume rate was 24, PEEP was 12, FiO2 was 100. He had, on this, he had a peak inspiratory pressure of 25 and a peak plateau of 24. His static compliance at that time would have been 37.5. And these were his initial post-intubation blood gases, pH 7.27, PO2 78, PCO2 58.
Ouch.
He also became hypotensive at that point and was started on high-dose Levophed and a vasopressin drip. Later that same night, the covering physician increased his respiratory rate to 28. He became more hypoxic, so she started him on inhaled nitric oxide at 20 parts per million. He was initiated on prone positioning, and repeat blood gases about 9 hours after doing all this showed a pH of 7.41, a PO2 of 362, and a PCO2 of 40. So he had a really big response either to INO or proning or both. And that morning, when I saw him, he was still on the high dose norepinephrine and vasopressin. So we started him on angiotensin II or Giapreza, and over the next 72 hours had a significant reduction in the other vasopressors to minimal doses. Now this is his chest x-ray on hospital day 3, which is really only 24 hours after ventilation on the ventilator settings that you see there. So he had a plateau pressure of 24 roughly. Now on day 3, which is day 1 after intubation, he's got a pneumomediastinum here that's pretty well demonstrated if you see this bright line. Bilateral infiltrates. So because of the concern over incipient barotrauma, his PEEP level was reduced. He was already at that point on neuromuscular blockade. During this 3-day period, there were at least 1 or maybe 2 unsuccessful attempts at stopping paralysis, during which he became dysynchronous and desaturated. He was sedated with propofol, fentanyl, and midazolam drips. He rapidly became off of pressors after the angiotensin II, and his FiO2 was able to be reduced during these next few days to 0.4 to 0.6. With reduction in his ventilator settings, fortunately, his barotrauma seemed to have resolved. No more pneumomediastinum, but on day 4 of mechanical ventilation, still has fairly significant consolidation in at least 3 or maybe 4 quadrants of the chest. Then on hospital days 10 to 14, he was still in the prone position. So at least almost 2 weeks of prone positioning. Somewhere in the midpoint of that, we started him on hydroxychloroquine and he received that for 5 days. There were several failed attempts at discontinuing paralysis, after which he would become dysynchronous and peak inspiratory pressures would rise and sats would drop. Around this time, his settings were APB-CMB, rate of 22, tidal volume 400, PEEP of 15, 40% FiO2 with a peak inspiratory pressure of 26. During this time, we added diazepam and oxycodone through the feeding tube. And then finally, on hospital days 18 or 19, which were after more than 2 weeks on the ventilator, we're able to stop prone positioning him. We're able to get him off paralytics. My partner came on and noticed that the patient had air hunger and excessive work of breathing. So we were on a Galileo or a G5 Hamilton ventilator. So he was switched to ASV mode and was found to have better tolerance of that. The settings were 100% minute volume, PEEP of 5, and FiO2 of 40%. Then on hospital days 20 to 26, he was extubated on the 20th day of his hospitalization, which was after 18 days on the ventilator. He initially had oxygen delivered via a mask, then an oximizer, then a cannula over the next 3 days. He was on Presidex even after extubation, and that was gradually weaned. it was noted that during an attempt at placement of a peripheral IV, that all the peripheral veins were noted to be thrombosed. And that was despite being on, at the time, 0.5 milligrams per kilogram of noxipirin BID. So when that was diagnosed, he was placed on full anticoagulation empirically. He had delirium and confusion that persisted over the next several days, and then finally was discharged on the 39th hospital day. This was his last chest x-ray in the hospital. This was day 35, which would have been 33 days after intubation, and shows basically clear lungs. Now here I've got several images of barotrauma that we've seen in COVID-19. This patient that I presented was one of them. He had basically a pneumomediastinum that you see here. Here's a patient with bilateral pneumothoraces. Here's a patient who also has pneumomediastinum and subacute emphysema. Here's a patient with free air under the diaphragm. This is the same picture. Pneumoperitoneum and subcutaneous emphysema. Here's someone with a large right pneumothorax. So we've really seen a fairly strikingly high incidence of barotrauma so far. All of these patients have been managed with low tidal volume, moderate doses of PEEP, just the same as we do with our other ARDS patients. So we're really kind of struck and surprised by the degree of barotrauma that we're seeing so far in COVID-19.
Thank you, David. Any questions for David about this patient?
Yeah, David, Geoff Shaw here. Like
Yes.
you, I'm a little puzzled about the barotrauma. Do you think that might be consequent upon a lot of ventilated asynchrony, which seems to be a problem that you've had all the way through? The patient was perhaps breath stacking or worse, and that may be something perhaps more of a problem with COVID patients than it is with you know, the run-of-the-mill patients.
Yeah, you know, I'm starting to look at that. I'm trying to look at it in a systematic way. So I'm trying to collect information on all of the mechanically ventilated patients with COVID that we've had since the beginning here, and you know, haven't worked completely through that. But what I've seen so far is that the patients I've seen who've had barotrauma, there's been about a dozen of them out of maybe 100 patients so far. It looks like they're mostly ventilated in fairly conventional modes of ventilation. APB-CMV is kind of our go-to, and it's all the patients are treated by my group. Their plateau pressures have been kind of similar to what we see in other patients with ARDS. We've been, just because of the uniqueness of this, we've been using a lot more paralysis fairly early on. Not all of them have had that. And I just reviewed the chart of one today who went a couple or 3 days before being paralyzed and did have fairly high distending pressures. And so that might have led to his barotrauma. But the others that I've seen have had fairly low pressures and have been paralyzed fairly early. So I'm thinking that it's something unique to the disease. I seriously have not seen this much barotrauma in 20 years, and we really haven't treated these patients much differently than we have all of our others. It's fairly striking.
Another question, not a criticism, a question. I noted that the respiratory rate early on was increased, and I presume that the normocapnia, the PCO2 of 40, was a result of that. Do you have, to what extent do you practice permissive hypercapnia in your unit? Because we would tend to CO2 and tend to ventilate them on lower rates and thus expose them to less barotrauma, if you like, if you will.
Yeah, I mean, I think that, of course, I practice within a group, and so I may be on service for 2 or 3 days, and then one of my partners picks up. And so there are a little bit of, there is some variation in the way we practice. I would say that I'm much more liberal with permissive hypercapnia than most of my colleagues, but I think they all kind of get that. I think most of my partners are trying to achieve a normal PCO2 in the first day or two, if it's possible, with reasonable pressures and respiratory rates. But I think we're all accepting of permissive hypercapnia to a certain extent. It seems like so far in the patients that I've seen with barotrauma that their tidal volumes have been around 6 mLs per kilogram predicted body weight. So we're kind of in that zone that we usually are with ARDS. Yeah. And maybe we could be more liberal with the permissive hypercapnia.
Yeah, I always think that's in Christchurch, as you know, the Pickling was the clinical director here in the early 90s and late 80s. And it was from here that the permissive hypercapnia was originally raised. So I guess the culture in our place is that I've never been bothered too much by raised CO2s except in the case of head injuries. And often I would turn the ventilator rate down sometimes and let the CO2 go up if I was particularly worried about barotrauma, knowing that every ventilation that you give every time you ventilate a patient, you're causing some lung strain and some risk of causing more injury. Follow-up question is, what oxygen targets do you use in your unit? I know the PO2 was 362 on a blood gas when the patient was prone. Do you have a process where you target a certain oxygen saturation and titrate the O2 up and down, or does it tend to be left to about the same and a blood gas some hours later would be taken and the O2 adjusted?
Yeah, I think, you know, we do have some issues here with, we try to give the respiratory therapists, and we have respiratory therapists here, you know, in America, who run the ventilators, some latitude, but we do have some problems with people allowing the O2 saturations and the PO2s to run higher than perhaps they need to be without weaning the FiO2. So I think that results sometimes in over-oxygenation. And of course, as you know, there may be some problems with that. So that's one of our ongoing projects, is to try to educate our staff that, you know, you don't ever need an O2 99 or 100% when you're on the mechanical ventilator. But not everybody gets that, and they're sometimes a little recalcitrant at weaning the FiO2 especially during the night shift. We see that happens. But basically, most of my partners and I are comfortable, especially in an ARDS patient with an O2 sat somewhere between 88% and in the low 90s. You know, what about you, Geoff? I mean, what are you targeting typically?
About that, what was really interesting, I 100% agree with you about the culture in the ICU. We took part in a clinical trial run out of Wellington. It was the ICU ROCKS study that you may have seen published. And so we had 2 oxygen targets. And I think when you get involved in clinical trials, that people are exposed to a different style of practice and they get some comfort with it. And so it's not uncommon for me to wander around in the middle of the night and see saturations of 91% in a patient who's on 30% O2. So staff haven't been inclined to turn the oxygen up. And we're now running patients on 25% oxygen and even room air frequently, which we never used to a few years ago. So we've actually had a change slowly in the culture in our units as to what our O2 targets are. The reason I ask the question is that I'm not sure about the relationship between oxygen toxicity, use it word broadly, and barotrauma, if there is any. But it's perhaps one thing to think about as well. There seems to be no point in using extra oxygen. It doesn't seem to be associated with any survival benefit, and may be associated with increased lung collapse and atelectasis and more lung injury. So, and the other reason I like to target a lower O2 is I can actually see subtle changes in the patient. So if they start to desaturate on lower levels of oxygen, I might do something to try and fix that rather than just letting the O2 be turned up or not be aware of it because the O2 has been high and the patient's moved from a PaO2 of say 300 down to a PaO2 of 90. You may not notice much difference on the stats.
You know, gentlemen, outside the United States, ventilators actually have modes of O2 control where the physician would say, keep the saturation between this range and modulate the FiO2 between this range. So almost a prescriptive device control that's available, again, outside the US. You guys may have used oxygen controllers or systems like that. And if so, I'd be curious as to your thoughts on that.
So David, oh, sorry, Ross, go ahead.
No, I was just to say, IntelliVent, Hamilton IntelliVent does that. It hasn't taken off much here yet, but it is available. Unlike the United States, we're not restricted quite as much by the FDA and other people controlling it. I was going to ask a specific question, but the steroids, did you use, given that they're now being shown to be beneficial, we would usually use, once we got into vasopressin, use a low-dose steroid regime to augment that. And I wondered, did you use steroids? I couldn't see that you had mentioned it, but I just wondered, did you use steroids at all in this patient?
We didn't actually in this patient. It's kind of a fun question actually. This was a patient that we treated. He was admitted in the very first week of March. So he was one of the first really sick COVID-19 patients that we dealt with in the intensive care unit. And after a few days in the ICU, well, first of all, he was mostly severe ARDS, and then his shock, septic shock, came a couple of days later. It was thought to be, he was thought by my partner who intubated him to have aspirated at the time of intubation. So that may have been a bacterial aspiration pneumonia on top of the viral illness of COVID-19 that caused his septic shock. At the time, we were being advised by multiple infectious disease specialists, both in our institution and elsewhere in the world, and sort of experts that steroids should be contraindicated in COVID-19 for a number of reasons. People cited the notion that there would be prolonged viral shedding, which I told everybody I don't care about. I want my patient to live. I don't care if they're infectious for a couple more weeks. But there were people who quoted some possible negative effects during the original SARS outbreak and H1N1 influenza outbreak. But I think for every article that suggests there was a negative impact, there's also a series that suggests that they were helpful. And in H1N1, I used steroids a number of times and found it, I had nobody die in H1N1 in my ICU. So we didn't use it in this patient. I actually called a friend of mine at the time when I thought he was sort of in a phase of non-resolving ARDS, a friend that I respected, and asked him whether I should use steroids, and he suggested that I use hydroxychloroquine, which also has some immunomodulatory effects. And so we did treat him for 5 days with that. And I don't know, I doubt that it had any impact, but he got over his septic shock pretty quickly. And then we were left more with the ARDS type picture. So we really didn't use steroids in this patient, but pretty much everybody else who's been as sick as him since then we have, with mixed results.
The Chinese described in the early stages, as you say, that uses of steroids seemed to suppress the symptoms, but they thought it prolonged the viral shedding and the infectivity, and they were concerned about that.
Yes.
And I think it was certainly reported, and a discussion we had with two of the guys involved in China was that they thought it was a real thing, that it softened it, but it prolonged it, and that was a significant problem when there was demand on health services, because you're having people in requiring care for longer. So it's interesting. The study now seems to suggest that it has a mortality benefit, which is a good thing. Yeah.
Dave, I noticed on the slides you showed and shared with the ventilator parameters that you had a driving pressure between 10 and 12. Is that something that you guys try and keep an eye on, maintaining or monitoring your driving pressure?
I do, but I think we're more focused on the plateau pressure in most patients, just because of the ARTS network and what we're typically doing in ARDS patients.
The surviving sepsis and all that.
Right, right.
Yeah.
So, hey, David, with regards to pneumothoraces, it's like you said, you've seen a whole lot of them, right? And you look at the compliance is not overly bad, I suppose 36 or so. Did you measure their compliance at all in prone position, not just supine, or was the compliance measured every day, or to get an idea of the changes?
I haven't really looked at it. I mean, as you probably know, in some of the studies that have looked at prone positioning, sometimes the compliance actually improves with prone positioning. It's interesting you asked that because this particular patient, for whatever reason, wasn't placed prone. Oh no, he was placed prone. I'm sorry. I'm thinking of a different patient I extracted some data on today. He was placed prone. I don't remember. I haven't really looked in detail at whether his compliance improved with prone positioning. But of the sort of the measurements that I've taken so far of these patients, they typically have reduced compliance like most ARDS patients, and like some of the recent publications have suggested. They're down in the 30s. They're not the really ill type patients that, again, nobody talks about. Maybe we're not intubating them early enough to see that, I guess, perhaps.
So just to follow that on a bit more, because and I was going to actually ask the same question that Steve asked about the driving pressure, because maybe that's a better way, maybe, of looking at these patients, how we ventilated them. For compliance is low. Is 6 mils per kilogram the right number? Is it maybe 4 mils per kilogram with more hypercapnia, a better approach? But also too, when you wean the patient using ASV, you had better synchrony and so on. I'm assuming that with ASV, you would have larger tidal volumes, but lower pressure. I'm assuming, right? Because the patient would determine their own tidal volumes and you just adjust the percentage. Was there a big volume difference?
That's probably what we see. I mean, I think we saw that in this patient.
Yeah.
And I wouldn't necessarily use it for that particular reason. Obviously, looking to try to minimize tidal volumes, but ventilator synchrony, patient comfort, and that appeared, my partner made the change in this particular case, and it seems like it worked out really well. The patient was very comfortable right after the switch to that. So he left him in that mode, and then that's how I found him. And basically,
so in a way, in the spontaneously breathing patient, it works more like volume support as opposed to pressure support, right?
ASV?
Yes.
Yeah, ASV is basically a volume support, if you want, similar to previous versions of that. Yeah.
Yeah. Okay.
I just thought it was interesting in this case. There are other patients that I've treated that we switched to ASV with COVID, that we switched to ASV thinking that maybe that would be more comfortable for them, and did not work out well. And really the answer for them, unfortunately, and this was in the weaning phase, unfortunately the answer was more sedation and putting them down until they would have less of a drive to breathe. And I would say, I mean, really, when I look at that, usually it's me, I come along after my partners have done this, and I look at their chest x-ray, and I see an x-ray that's worse than all of the ones that I just showed you. And I go, well, it's a no-brainer. If you've got, severe diffuse pulmonary infiltrates, you're probably very stiff. You've got signals triggering, you to overventilate, and it's probably not going to work out that you put somebody on low level of ventilatory support and expect them to do well, independent of what the oxygenation is. Because oxygenation always improves quicker than the chest x-ray.
because they're consolidated and they have low compliance, maybe they're overpeaked. Because normally you assume that a patient who's got consolidation is not going to respond to PEEP the same way a patient with atelectasis is, right? These are
well, 2 or 3
maybe?
weeks into the ARDS, they may not be all that PEEP responsive. Yeah.
Yeah.
I think.
Patrick, what do you think?
Yes, I've been looking at the pictures that David has shared. I haven't been able to share on this occasion our data. I will be working on that. And they look quite similar to what we have encountered, but I shall share with this at a later date. And I think that more or less we have been doing similar things, sedation for quite a long period of time, about a week before we attempt to come off. And when we do, we have been using on our ventilator, PRVC. And then when we are able to take off the muscle relaxation, we go to volume support. Luckily, our transition period coming off and waking up has not been too difficult, and we were able to wean them off. But I will show the data at a later stage when I can get hold of it.
Great. We look forward to that. David, I noticed. Sorry, go ahead, Ross.
Just I want to go back to what Geoff was talking about, the high rate of barotrauma. I remember in early SARS, there was a lot of barotrauma as well, which was attributed to poor ventilation technique, but in fact may not have been so. It may have been simply the disease itself. It's certainly a lung destructive disease, and although we focus on poor ventilation and high pressures and gas trapping, it may be simply a destructive phenomenon that's destroying the tissue, and pneumothoraces may be more common than we think they should be. It'd be interesting to know if patients who aren't ventilated develop pneumothoraces, which would sort of suggest that in fact it's not the ventilation per se, but I've not heard of any reports of non-ventilated patients on oxygen alone that were developed barotrauma.
Those are fantastic points. You know, as soon as I saw 3 or 4 or 5 incidences of barotrauma, I went and looked at the literature, tried to see if there was anything that supported this. And what I found was fairly quickly was a report from the 2003 SARS outbreak. There was a series from, I guess it was from China, and a medium number of patients, I think in the 50s, mechanically ventilated in ICU, and they reported a 26% incidence of barotrauma, ventilator-induced barotrauma. And they went so far as to say that they were already using low tidal volume ventilation. The ARDSNet study had already been published a few years before. They published their data in terms of low tidal volume ventilation. And they were rather surprised at the time. And 26%, barotrauma is pretty unusual in the current era of low tidal volume ventilation for typical ARDS. So I'm thinking that there might be something specific to this coronavirus infection that causes perhaps some necrosis of areas of the lung that results in air leak. We know that it has, microvascular thrombotic effects and endothelialitis. So I think it might be part of the destructive nature of the disease that leads to that. I don't think that I've seen barotrauma in someone who wasn't yet intubated, but I've seen several cases right now who showed it on their first or second chest x-ray right after intubation. And typically, we're sedating patients heavily, we're paralyzing them. They're not bucking the ventilator a lot in the first 12 or 24 hours after intubation with this disease. So that's kind of surprising. Usually back in the day when I would see barotrauma with ARDS, it was like 3, 4, 5, 6 days into the run.
Yes, I note that in our series of about a dozen patients. The first patient was a very, very stiff learning curve for us. In retrospect, perhaps our strategy to use high PEEP actually worsened we had a lot of barotrauma in that case.
Yep.
And it didn't work out well. But after that, we had better information on H and L, and we were able to manage it much more correctly. So I just want to concur with David that yes, barotrauma was an early problem with us.
So David, I also noted you mentioned 18 days on the ventilator. Is that what you're seeing in terms of a norm? Are these patients that present themselves and aggressively are quickly placed on the ventilator that present themselves in this condition? Are they going the course of around 2 weeks plus?
Yeah, I think that ours who have survived typically have been around 3 weeks on the mechanical ventilator. And, if you look at now, there's a couple or three published series from other, major centers in the world that the patients who survive are taking somewhere around 20 days of mechanical ventilation. Those who die usually do so within the first week to 10 days being on the ventilator. So we've had a number of patients now who've actually had tracheostomy. And we're, like I think a number of other centers, we're being very judicious about tracheostomy. We normally would be advocates of early tracheostomy, but we're not doing that in these patients until, at least I would say almost all of our patients who've had trach have been 3 weeks or longer. We're waiting till their COVID test turns negative, even though there may be some problems with that in terms of the accuracy. But yeah, probably 3 weeks would be an average.
Okay. And did this guy present sicker than most, or is this kind of how you're seeing them coming in, where they are basically within 2 days to, I know he complained about, you had some data that there was 4 days PTA and then 1 day worsening shortness of breath. Are patients showing up in poor condition? They staying out of the hospitals for fear of COVID when they have COVID and then presenting themselves in worse conditions?
No, I would say of the charts that I've reviewed and the patients that I've seen, I don't see that tendency. This guy was, by his history at least, only sick for about maybe 4 days before he got intubated. There was another guy, I was just reviewing some data on doing some case series, and he was sick for 2.5 weeks before he ever came to the hospital. He was even on oxygen in Mexico before he came to San Diego. So, there are those patients, and I think those are the kind of patients that we heard about probably from Northern Italy early on who, they came to the ER and all of a sudden they crashed. We're not seeing that so much. We're seeing people come in, they've got some symptoms. Everybody's tuned into the notion of COVID-19, so they get tested, they get admitted, they get on low flow oxygen or a mask, and it takes them a few days either to declare themselves as critically ill or to make it through. So we're not seeing that many who present fulminantly like we've heard about. And this guy really didn't. Well, I guess he really did, but he'd been to the urgent care twice, to be fair, and then finally showed up in the ER, and then he got intubated the same day he got admitted to the hospital.
So David, how many patients have you seen so far?
In the 3 hospitals that I work in, or that my partners and I work in,
yes,
which have 100 ICU beds normally.
Mm-hmm.
So that just gives you an idea. So three hospitals in San Diego with normally 100 ICU beds. From first week of March till the first week of June, there were like 182 mechanically ventilated COVID-19 positive patients in those 3 hospitals.
And from a ventilation perspective, has anything changed? Have you made different strategies? I mean, this example you gave, we maybe the PEEP was too high or the tidal volume or the pressure or whatever it was. Have you changed any strategy in how you manage them?
Well, I mean, I think like a number of people, when the Gattinoni publication came out, or the pre-publication, the editorial describing the L and the H type, I personally started paying attention. I think my colleagues did as well. We did see some people who early on intubated who had, you know, static lung compliances or static thoracic compliances of 40, 50, even better. And so we gave them a little bit higher tidal volume and saw how that went. Subsequently, I think we pretty much automatically put them all on 6 milliliters per kilogram predicted body weight and just gone back to what we normally do. A couple of my partners, like APRV or dual PEP, as it's called in the Galileo, or the G5, but not very many patients that we manage that way. Mostly in, you know, APV, CMV, or pressure regulated volume control. So we're basically adhering to sort of normal ARDS network guidelines right now.
So you're not throwing the baby out with the bathwater.
Trying not to.
All right.
Could be wrong, but yes, we're doing what we think is right.
Okay.
The only difference I see in these patients is that for some reason they have an exceptionally high drive to breathe, and we're having to use very high doses of sedation and much more paralysis than we normally would. So after the French article a few years ago, yeah, we were fairly liberal about using cisatracurium, you know, for 48 hours in our early ARDS patients, just based on that article. And then when the subsequent one came out that suggested maybe there's not a mortality benefit, sort of cut back on that, but we still use it in patients who are dysynchronous or just, you know, can't be oxygenated. Well, then COVID came along and almost every patient intubated is on a paralytic at some time. And that would not have been the case in our units 1 year ago.
Was his delirium and confusion post extubation, was that associated, you think, with the high levels of sedation, or are you seeing this in general with your awakening and you know, post ventilation COVID patients?
I'm seeing a fair amount of it. I think it probably is our fault from, you know, the amount of sedation we're using, but we're doing what we think we need to do. It's hard to say. Is it a viral encephalitis or is it drug related? It's probably a little bit of both.
And then I had a question for you. I sneaked ahead and looked at your slide set and started thinking about barotrauma and post-ventilation, the recovery of patients' lung function post-ARDS, and wondering what you guys believe we're going to see post-COVID. You know, ARDS has kind of been known in the literature or demonstrated to show lung function recovery after a year. In general, most people are able to present with normal pulmonary function testing after a year. Is anything more significant here, such that we may not see that kind of recovery of lung function a year from now after they've been discharged?
I think, you know, I think there's some signals that suggest it might be worse than what we would expect. So I think if in fact there is more barotrauma, gross barotrauma associated with this disease than there would be with all of the other causes of ARDS, that we might, that might be a signal that suggests that there's more destructive lung tissue destruction that might lead to more prolonged lung dysfunction. You know, the anecdotal things like seeing the excised lung of that woman in Chicago who got transplanted, that's impressive, although that's just one case. And you know, I'm sure there are lungs at autopsy from H1N1, especially if there was secondary bacterial infection that would look just as destroyed. So, I mean, you can't really rely on those kinds of things. I think that it just remains to be determined. But I think that if in fact the data shows that these patients spend more time on mechanical ventilation, that's probably going to lead to more lung dysfunction for a prolonged period of time. So I don't know. That's all I can say about that.
That question was brought about just looking at the x-rays, being amazed with what was being presented on the radiologic data.
I think you're right, actually, Steve, because if you look at the so-called like the broken glass effect inside a lot of their lungs from this microemboli, sure there's going to be fibrosing and then long-term effects of getting back to a normal ever lung function it's going to take a long time. So I think the follow-up is going to be pretty important, right? Because these patients, their tolerance is going to be questionable the whole time.
Well, this has been great. David, I want to thank you for sharing and everyone for participating. We'll continue on, but I really want to thank you all. And again, I want to make sure that I close this session again with everyone breathe easy and take care.
Thank you, Steve.
Thanks.
Thank you, David. Thank you,
Thanks,
Patrick,
Steve.
Ross, Geoff.
Thank you, Steve.